Hi, my name is Candace Middlesdorf.
And my name is Stacy Page.
And today we're going to talk to you about infection prevention, and more specifically, infection prevention when placing a urinary catheter. CAUTI, which is catheter-associated urinary tract infection, has increased across the country. So we want to bring this to y'all and just make sure that everyone's aware of its importance. According to the CDC, 15 to 25% of patients in the hospital receive a Foley catheter, and it's inappropriate. They really shouldn't have it in place. And there are some indications that we're going to discuss about catheter placement.
CDC does have some guidelines and indications for patients that can have catheters. One indication would be for patients in peri-op surgery, or that is having surgery. An example would be urological surgeries, or surgeries or prolonged surgeries would be a really good indication for urinary catheter use.
Another indication for use that would be appropriate is a patient who has strict hourly urine output needs, and that would be, for example, a patient in the ICU or a critically ill patient.
Another indication would be urinary retention or urinary obstruction. That would be a very good indication for a urinary catheter.
Another indication would be a patient who has a pressure ulcer or a patient who has a skin graft. And this is a pressure ulcer, a stage 3 or 4, that is in the peri area. We don't want to have a catheter, or we would like to have a catheter in these patients just to help prevent urine from getting into those sites and wounds.
Catheter use, or by the CDC, also says that prolonged immobilization is an excellent use for or an indication for urinary catheter use. Prolonged immobilization could be patients that could have a spinal injury. That's a good indication use. Not a good indication use for prolonged immobilization are patients that may just be on bed rest for a couple of hours at a time post-operative, or patients that are requesting to have a urinary catheter, or patients who just do not want to get out of the bed at that time. So that does not meet the criteria for prolonged immobility.
And a final example of appropriate use would be a patient who is end of life. They are requesting a Foley catheter just for comfort reasons.
When we're thinking about CAUTI, or catheter-associated UTI, that is a hospital-acquired infection. That can actually account for 30% of hospital-acquired infections in the hospitals. When we think about CAUTI, or the significance of CAUTI, or why we want to speak to you about this, CAUTI, or catheter-associated UTI, a UTI can develop into urosepsis. Sepsis can develop into septic shock, and then an ultimate outcome of septic shock could be death.
And we're always here for our patients. We want to be concerned about our patients and preventing infection, but we also need to look at the hospital. As far as the patients who develop CAUTI, we want to think about that they're going to have an increased length of stay, and they're going to have that increased morbidity, mortality, and this can ultimately increase the cost of their stay in the hospital, which is going to increase the cost for the hospital.
When we're thinking about CAUTI, and always our eye is on the patients, we must think about the economic and the public awareness of infection rates and the due to nursing advocation of the facility as well. So with public awareness and the vast abundance of information that is easily available, think about CAUTI when you're thinking about, take it for example of Yelp or a TripAdvisor when you're going to look for a new restaurant. When you go to find a new restaurant, you're probably already looking for the rates, health grade ratings, health department ratings for that restaurant. Patients are now able to do that with facilities as well. So they're going to be more prone to go to a facility that has decreased infection ratings versus a facility that has more infection ratings. So they are able to easily compare those to hospitalgrades.gov or hospitalcompare.gov. Those are some good websites to compare catheter-associated rates or central line infection rates. So with the vast knowledge that you can easily get online.
We also want to talk about some signs and symptoms of CAUTI or just a general UTI. The patient can have a burning sensation when urinating. They may also have blood in their urine. They can have pain in their peri area, or they can also develop fever. And I want y'all to understand that just because a patient has a catheter in place, they might not develop these symptoms. So we want to watch out for other signs and symptoms just to prevent the patient from having a CAUTI.
When I'm thinking about prevention of CAUTI or prevention of infection in general, there's 10 maximal barriers to prevent an infection. 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So your hands to prevent, or the first line of defense for infection is proper hand washing. That's always a good line of defense to prevent infection. When we're thinking about CAUTI though, to prevent a CAUTI in the first place is to consider, do they need it? Don't put it in is the number one prevention of CAUTI. And then number two, get it out as soon as possible. Think about that every day. Advocate for that patient every day. Does the patient need it? Does the patient meet the criteria that we've already spoke about? Immobility, pressure ulcers, retention, obstruction. Think about that every day. Because every day that patient has a catheter in place, whether you've done aseptic technique for insertion or you've done catheter care at least every day or every shift, the patient gets a 5% chance of CAUTI just with that catheter being in place.
So now let's just recap for a minute. So we've talked about CAUTI, what it is. It's catheter-associated urinary tract infection. We've talked about the indications for placement, and those are things that you should consider before putting this catheter in your patient. We've also talked about some signs and symptoms, and we've talked about the impact. There's a huge impact on the patient. They're at risk for this infection. There's a huge impact on the hospital. If a patient does develop this type of infection, it's going to, cause an increased length of stay and increased cost for the hospital. And then it also impacts our community. Our community is not going to want to come to a hospital that has higher rates of CAUTI. So now we're going to talk about actual insertion of a catheter. Stacy is going to demonstrate the insertion of a catheter using a kit.
What I'm going to do is, Candace and I'm going to use a kit, a manufactured kit that gives uniform steps. And what we'll do is I'm basically going to come into the room, and I'm also going to have a buddy. And Candace is going to talk to you a little bit more of why I have Candace as my buddy in the prevention of a CAUTI.
So during this presentation and during this insertion of the catheter, I'm going to be Stacy's buddy. The reason for having a buddy with catheter placement is it's just a second set of eyes. When Stacy is placing the catheter, I'm going to be her second set of eyes to make sure that she doesn't break sterile or aseptic technique, just to make sure that we haven't put that patient at risk for CAUTI. I can also be here to be comforting for the patient. I can hold Miss Smith's hand and just let her know, what's going on with the procedure. And I can also help hold a leg. We occasionally have patients that move around a lot in the bed, or we just need help holding the leg out of the way to ensure that they don't break the sterile technique and cause increased risk for infection.
So I'm going to do a brief overview of insertion. While Candace also gives a couple of overview bits of insertion as well. So as Candace, we've already came into the room. We've already washed our hands thoroughly. We also are going to put on our clean gloves. We've already explained the procedure to the patient and to the patient family. We've also verified the patient with verbal confirmation of her name, date of birth, and we've also verified it with the patient's armband as well. And we've also verified allergies as far as latex and betadine. So this kit is, we're going to do a quick overview of the kit as far as insertion and the uniformity of this kit. And so Candace is also going to explain why we do have uniformity of this kit and why we're going to do this, to go over the steps of this kit.
So while Stacy's getting that ready, I just wanted to talk for a minute about the importance of having these uniform kits. There's different manufacturers out there, and it's just very important for the patient to have a step-by-step so that if I'm going to insert the catheter or if Stacy's going to insert the catheter, we're doing it in a similar manner, and we're doing what is right and what's evidence for the patient to help prevent CAUTI.
So what we have first is patient education. And I'm going to have Candace talk to you a little bit more about patient education. This card does come in this particular kit, but patient education is always very important during, prior to, during the procedure, and definitely after procedure as far as care and maintenance. So I'm going to have Candace talk to you a little bit more while I'm continuing to go through my kit prior for insertion.
So, like Stacey said, education is very important for the patient and for the family. So we would want to tell the patient and the family that, you know, you need to tell them every day and just ask, do I still need this catheter in place? Is there any reason why I still need to have this catheter in? Just to encourage them to help with getting the catheter out. You also need to make sure that the catheter is secured, and we will be placing this catheter in a securement device. You want to encourage the patient not to tug or pull on the catheter. That is just going to increase irritation in there, and it can cause an increased risk for infection. You also want to explain to the patient that the Foley catheter bag should be below the level of the bladder. You don't want the urine to go back into the patient. You want it to drain naturally. Help remind them, you know, don't have it all wrapped up in your legs. We need to keep this catheter straight so that it encourages proper drainage.
So also on the top of the kit was a sticker that you would be placing on the patient's urine drainage container or the bag to basically put the unit that it was placed in and the date. The date gives us a visual reminder to let us know how many days has it been placed. It gives us to help advocate every day how many days has it been in, 2, 3, and 4. So be sure to label your urine drainage collection container to make sure we give a visual reminder to make sure that the dates do not get away from us. So basically, as far as we were talking about evidence-based, is that urinary care or pericare should be provided prior to catheter insertion. This has been proven to reduce the risk of catheter-associated UTI. So basically, I have 3 towelettes, Castile towelettes, and I would provide pericare to this patient prior to insertion. So as far as a female, I would take my 3 towelettes, 1 towelette each, so 1 swipe, and toss in the trash receptacle, 1 swipe down the other labia, toss per the trash receptacle, and then 1 swipe down the middle of the labia. And that would be my pericare. And then I'm going to take off my pericare gloves, and then I'm going to perform hand hygiene, whether if your particular kit has a hand sanitizer pack, or if I need to go and actually go wash my hands with soap and water. So we're going to continue to go through. We want to make sure that we do not break any type of clean technique or aseptic technique, opening up our sterile kit as well. So you should be sure that the last fold opens up toward you as far as putting this in. Okay, so the last fold has fallen toward me. I'm going to only pick up my sterile gloves outside the kit, and I'm going to put these on a bedside table. That way my back is not toward the kit, nor am I going to use the patient as a bedside table, nor am I going to put these gloves on the sterile kit as well. So I'm putting on my sterile gloves. And I have Candace watching me very closely to make sure that I have not contaminated myself or my gloves. First thing that we're going to do is put these drapes shiny side down. This is basically an extension of my sterile field. Okay. We're going to make sure that we properly drape her. This has also been shown to decrease CAUTI. So if the patient's properly draped appropriately, it will decrease CAUTI. So you can also see that these drapes used to be on the outside of the kits. Now new evidence has shown if it's on the inside of the kits and used properly, it will decrease CAUTI. And we're going to use our fenestrated, which will go on top of the patients. Okay. We want to make sure that we do not touch the patient with our sterile hands. First thing, it's like when we say 1, 2, 3 or ABCs, it's where everybody's going to do things at the same time. So 1 is open up the iodine, 2 would be pour it here, and that's where everybody's going to do it the same way. Alright, and 3 is attach the water syringe.
So while Stacey is attaching the water syringe, I just want to point out that we are not checking for the balloon. We're not going to inflate the balloon. It's no longer recommended to actually inflate the balloon prior to insertion. This just causes extra kinks and little indents in the tubing, and that can cause irritation and increase the patient for CAUTI.
So we're going to continue where our step-by-step goes, and we're going to put in our lube where it says, our lubricant. And here you see that I'm not twisting this all around my hand. I'm not letting this fly all over my sterile field. And I'm going to set this down in my lubricant and remove the sterile shroud. Alright, and so the next thing I'm going to do is go ahead and prep the patient. And so now my left hand is going to be no longer able to touch the kit. So here I'm basically going to prep the patient with individual swabs. So I'm going to open the labia, and so I'm going to do one swab and toss it, one swab down the other labia and toss it, and making sure that my swabs do not go back and forth across this sterile field. You want to keep it back as far as you can away from back of your sterile field, and then one swab back down the labia, down the middle. There's no up and downs or swirls going down there. It's just one swipe down each and every time. Now, if for some reason the labia does close back, that's when my buddy does come in place, and then we need to start back over, and she'll get me some new betadine swabs. So now I'm going to insert, making sure that my fingers do not touch the patient as far as my sterile hand. Okay. And so on a female, it's going in. I'm making sure my sterile gloves do not touch. So on a female, once I see urine, I'll advance it 2 to 3 more inches. I'm going to inflate the balloon, okay, all the way on a patient. And then what I will do is give it a gentle tug to make sure that it's seated in the bladder of the neck there. All right. And so then we're going to talk about the care and maintenance and the securement of this device.
So now that Stacy has placed the catheter, we do, like I said, it's patient education. It's just best for the patient to make sure this catheter is secure. So we're going to secure the catheter with a leg device. It's going to be on the top of the thigh. You don't want it to kink or coil any. If this catheter is kinked by being placed in this device, that does increase the patient's risk for infection. We also would like to lay the catheter tubing. We want to make sure that it is all the way straight. We don't want to have any kind of dependent loops. These dependent loops can actually increase the patient risk for infection as well. It's going to cause what's called a biofilm, and Stacey can explain that more in just a minute. And after we make sure that it's all the way straight, we're going to place the catheter below the patient's bladder just to ensure proper drainage.
So when she's talking about dependent loops, it's basically when you have a dip in the tubing and then it has to rise back up into the bag, okay? It should make a straight all the way down and then have to dump into the urine container. But if you see a dependent loop or if you see it make a dip, biofilm will collect. And so my terminology for biofilm is if you have a pet, dog, cat, you have a water bowl, you water your pet, you give your pet some water after working for 12 hours, and then you come back the next 12 hours, give them a little bit more water, and then the third day it's time to clean that water bowl. At the bottom of that water bowl is a little slippery, slimy substance. That's called biofilm, and it's basically a bunch of different bacterial molecules that has gelled together, basically. That took about 2 or 3 days. But biofilm is basically can go in a couple of hours here in this tubing if urine just sits here. So that's why we say it's very important to make sure that the urine does not collect here and you don't accidentally give it back to the patient into the bladder. And that can easily cause another catheter-associated UTI.
So just to recap, we wanted to make sure that you knew what CAUTI is. It's catheter-associated urinary tract infection. We talked about all of the appropriate indications for placement of the catheter, and you really need to be the patient's advocate as far as getting it out in a timely manner. If it's not even appropriate, don't put it in your patient. We want to do everything that we can to prevent a CAUTI from occurring. We also talked about some of the impact that's going to occur, and that's for the patient and for the hospital. And then we went through the proper steps of placement just to help prevent a CAUTI from occurring and actual maintenance. One other tidbit about the maintenance, we want to make sure that we're doing peri-care on these patients and catheter care at least once a shift, just to ensure that it's being kept clean.
Thank you so much for listening to us and our presentation on catheter-associated UTI. We feel that this is very important for our patients, and we'd like to improve our patient outcomes with the decreased use of catheters and the proper use of catheters and the proper use of catheter care and maintenance.
Thank you.
Thank you.